Lakshmi, can we start?
Yes, ma'am.
Yeah. Good evening, all. Welcome to the third day of the webinar series with the theme First 1,000 Days of Life in commemoration of the World Breastfeeding Week. I take the privilege to introduce our speaker for the day, Dr. Anuradha Kedilkar. Madam is going to present on importance of assessment and monitoring of growth during first 1,000 days. Dr. Anuradha Kedilkar is MD in pediatrics, is a senior researcher. Lakshmi, can we have the slide, please?
Yes, ma'am. Yeah. Fine.
Is a senior researcher with 25 years of experience in basic research. Dr. Anuradha is Deputy Director, Hirabai Khawasji Jahangir Medical Research Institute, Jahangir Hospital, Pune. She is consultant pediatrician, Jahangir Hospital and Jahangir Clinical Development Center, Pune. More than 180 publications in index journal she has to her credit. Over 50 completed research project, very rich. Over 500 presentations in state, national and international conferences, and 309 awards for paper presentations. Guide and co-guide for 20 plus PhD students. Field of interest is nutrition, growth, endocrine disease, vitamin D, and bone health, and type 1 DM. I will place here recent awards of Madam. Received an Investigator Award for Excellent Research for a Study on Adolescent Pregnancy at the 9th International Conference on Children's Bone Health, held at Salzburg, Austria in June 2019, received award for the Best Original Research for the paper Prevalence of Osteoporosis in apparently healthy adults above 40 years of age in Pune city, India in November 2018 by Society of India and Indian Journal of Endocrinology and Metabolism. Received second prize for oral presentation at the Indian Society of Pediatrics Endocrinology in November 2017. This is very brief what I have told, but how we know Dr. Anuradha Kedilkar is, me and Lakshmi, that is the treasurer of the NSI chapter, Bangalore chapter, we have heard Madam in 2 incidences. She has presented a very, very well elaborate work on monitoring, growth monitoring. So I request all of you will have a very good, food for your thought and your brain today with Madam. With this introduction, I request Dr. Anuradha to take over the session.
Thank you so much, Dr. Sundravali. Thank you for the kind introduction and for having me here today. And thank you to NSI Bangalore and all the organization that has gone behind this. So I will straight start with sharing my screen. So today I'm going to speak on the importance of assessment of monitoring of growth during the first 1,000 days. And we just go. Yeah. Just give me a second. Yeah. So if you actually look at the first 1,000 days, so I know a lot of you must already be aware, but the 1,000 days actually starts when the baby is in the mom's womb. So the first 270 days is when the baby is in the mother's womb. And then you have the 365 and 365, which means that this is actually till the baby or the little one is 2 years old. So really, apart from feeding mothers well, we and making sure that girls grow well during their pubertal years, we cannot do very much about the first 9 months. Where I'm going to start today is with the early postnatal or during infancy. That is where I am going to start. Now, infancy is the first year of life, And just give me a second. I don't seem to be able to go down on this. Yeah. So why do we have to monitor growth in the first 1,000 days? So it is a period of very rapid physical growth. So I'll come to this once again to, explain what this is, and also very rapid mental development. So it's always like this, those times in a child's life when a child grows very quickly, you can actually take a lot of care to make sure that the child grows well. And this will be a unique opportunity to build lifelong health and intelligence. But if you look at it the other way, then you can fall back also very quickly. So if the nutrition is poor during the first 1,000 days, it affects the not only the physical growth but the cognition, or what we call as development. A baby, when a baby is born, it doesn't even smile at you, and by 2 years the child baby is generally talking sentences, walking around. So the development during this time is very, very fast. Sadly, malnutrition is seen in almost 50% of children under 2 years of age. And the reason for that is, of course, poor food intake, etc., etc. Also, in India, mortality is still around a 40 per thousand live births, which actually is quite high and really, really needs to come down. So I think seminars like this can really contribute towards that. Now, I'm mainly going to concentrate on the growth because that is my area of work and has been for the last 25 years. So, in the first year of life, now I'm going to talk about physical growth. So, first, let's talk about length or height. So, as you know, till 2 years of age, children are, it's very hard to get a child to stand, and you actually have to measure the length. In the first year, a child grows a whopping 25 centimeters. In the second year of life, 12 centimeters. And in the third year, the growth rate starts growing down a little. It is around 8 centimeters. This is the average. So as you can imagine, the 25 and the 12 centimeters, which is almost 37 centimeters in the first 1,000 days. If you look at the birth weight, generally the birth weight is anywhere between 2.5 to 3.5. I'm sure you all are aware that under 2.5 is actually classified as low birth weight. In the first 3 months, a baby grows around 30 grams per day. In the from 3 to 6 months, it's around 20 grams. And then the growth rate goes down. The increase in weight goes down a little. And from 1 to 3 years, it's still around 3 kgs per year, after which it reduces a little bit more. So in the first 1,000 days, you're looking at up to 3 kgs a year. That is the least that you grow. You could even grow more. Now, the third important parameter is the head circumference. So the head circumference is around 33 to 35 centimeters at birth. And I think head circumference actually, tells you how important the first 1,000 days are, because it practically reaches the adult circumference by 3 years. So between first to 3 months of life, it grows around 2 centimeters. And then you can see I've put it down here that how it grows between 3 to 6, 6 to 12, and then 1 to 3 years. So in fact, in a healthy child, generally after 3 years, we stop taking head circumference. So these are the three most important parameters that we look at when a child comes to us in a clinic, or when we are even looking at children in Anganwadis or in daycare centers, which is also where we work. So we actually call this as an ICP model. Right now, we are looking at only the I bit, which is the infancy. So infancy, or up to 2 years of age, growth is mainly driven by nutrition. So nutrition is very, very important in all phases of life in a child. So we call it the I infancy, C childhood, and P puberty model. So till 2 years, the most important factor is nutrition, and that is why it has been picked up in the first 1,000 days. Then in childhood, there are also hormones which come in, though nutrition still matters. And in pubertal years, it's also the sex hormones and GH, growth hormone, which comes in. But nutrition is important at each stage, but critical in the first 2 years of life. So how will you assess nutrition? The easiest way is anthropometry, that is measurements. So what is anthropometry? So it is the measurement of the size, weight, and even proportions of the human body. Now, the proportions comes in the definition of anthropometry, but we don't usually measure proportions in little ones, not up till 2 years. We do that a bit later in life. Now, what we normally measure is weight, which is the commonest measure, height or length, the head circumference, and the mid-arm circumference. These are the anthropometric parameters which we most commonly assess in infants. Why anthropometry? Why not some other method? Why not blood tests? It's inexpensive, it's non-invasive, and it helps to assess the size as well as the proportions, which I know I said we don't require so much in little ones. So anthropometry can reflect not only the nutritional status, but it also is a very good indicator of health. So at the roughly the end of my presentation, I'll take you through 3, 4 cases to show you how important anthropometry is in health and how much we rely on it as pediatricians or healthcare workers for children. So there are the aims of anthropometry are of course to assess normal growth. Remember, just as assessing normal growth is important, assessing abnormal growth is important. Also, reassurance of normal growth is very, very important. Then to identify children who are deviating from normal growth, underweight, and also overweight. It doesn't happen so commonly in very young children, but in older children, overweight is quite common. So I think that is something we have to keep in mind. Identification of disease states. I will tell you a little about this when we come to our cases. Then it's very important in population surveys. Nutritional and health status of a country is actually defined by the maternal mortality, the infant mortality, and the health of children, the growth of children, the stunting and wasting in children under 5 years of age. Then also to see how far your health promotion is working, such as your feeding, your hygiene programs, your immunization. To see that, you need to have growth monitoring or anthropometry, and to help us in educating parents to allay their anxiety about child's growth. So anxiety in parents is something that we talk about, but also what we find is that if you actually have a growth chart, even in the poorest of schools, you will find that the parents are very keen to see that their child lies in the green zone. So how do you actually interpret anthropometry in children? So one of the things about interpreting anthropometry is that you need to compare it with growth or reference charts of normal children. So for us, many times, the first time a child is brought to us and a mom or a dad says that the child is short is when the child goes to preschool for the first time or goes to a playgroup where the mom or dad realizes that the child is actually shorter, fatter, thinner, whatever, than his or her peers. So really, they are once they're able to compare the child is the only time that you know your child is not doing well. So that's exactly what we healthcare workers with children or pediatricians do. We compare them with charts of normal children. Because if you say a 1 year is 70 centimeters, doesn't mean anything. You actually have to look on a chart to be able to tell whether he or she is normal or not. So what are the parameters that you would normally assess? The most common one that is assessed is the weight. It is most widely used. It is quite reliable. Uh, Periodically recording on a growth chart is most important. Remember, when you are doing a baby and the baby's nappy is unfortunately very, very loaded, you can get 200-300 grams here and there, which also I find scares moms a lot. One of the advantages, of course, is it is a indicator of nutritional status. It is important in nutrition interventions, apart from the fact, like we saw earlier, that it's very easy to do. The follow-up is for follow-up of nutrition intervention, it is very good. You don't need much cooperation from the baby because for a height measurement, often you need the baby to cooperate at least a little bit with you. Here you can just plonk the baby onto a weight scale and you can get the weight. One of the disadvantages is that it does not account for height. That is where the weight for height comes in, or in older children or adults, the BMI comes in. For instance, a tall child, the a weight of if a little one is 10 kgs and his height is 75 centimeters versus the height is 68 or 65 centimeters, that makes a lot of difference to the ratio of the weight to height. That is why, because weight does not consider height, we have to do the height as well as the weight for height. So like I said, till 2 years you have to do length. This is a bit of a job for the specialist because you actually need two people. You need somebody to hold the child's head. You need to hold the child's leg. You need to make sure that the knees are not actually lifted. Otherwise, a couple of centimeters here and there is very, very easy in a little one. Also, it is not a very good indicator of current nutritional status. So we call it attained height. What that means is it is an indicator of the past nutritional status. So if you have a child who has been sick for the last 15 days or 18 days, you won't see any difference in the child's height, or you may not see particularly in an older child, but it is a very good indicator of chronic illness. That is one of the reasons why we as pediatricians have insisted that please take height, because the weight may be okay, but the height may be less. So what you have could be chronic malnutrition. So if you look at the other a picture on this slide, you can see that one of our research fellows is actually measuring height of a little girl. And as you can see, she is down on her knees. And the reason for that is when you are measuring height, you need to read it at the level of your eyes need to be at the level of the board on the child's height. If you don't do this, you could get the height wrong, and say next time you have, the child shrinks, you have no face to show. So you have to take height and weight carefully. I'll come to that once again a bit later. So up to 2 years you use an infantometer. You take the cumbent length, and in older children you take height. So really in the first 1,000 days, what you're doing is doing recumbent length. Now, I spoke about the weight for length. We'll also see a chart for that later. So this is also an age independent criterion. In the current days, it doesn't happen that a child doesn't know or a parent doesn't know the child's date of birth. But in the earlier times, this used to be very useful. Another thing is that it expresses the weight as a fraction for the height, and that is very, very important because, as I said earlier, a taller child will actually have more weight just because he or she is tall. Also, the weight for length is a better indicator of the current nutritional status. Unlike just the weight or just the height, you may know that in SAM, MAM, weight for height is the one that we use, and it's less variable with age and also ethnicity. Of course, right now we see mainly Asian Indians. One more parameter that we use is the mid-arm circumference. So the mid-arm is not something that we use in our clinics or even in health checks or camps, but it is a very good procedure if you want to actually do a population-based study. And there are WHO tapes, UNICEF tapes, there are WHO parameters where you can use this to quickly get a judgment of whether the child has malnutrition or not. And it can also be done by somebody who's not very trained to take height and weight. The only thing you need to know is where to place the tape correctly, because you have to measure between the shoulder and the tip of the elbow, which is called the olecranon, and in between you have to take the measurement. And the head circumference, so that is also the tapes that you always use for this are the non-stretchable tapes, and you actually use it between the occiput and the glabella, and we generally take it till 3 years of age. Now, if a child say, the weight is around 200 grams, 300 grams in a young child, less than what you would expect, you might still wait and see what is happening. But if you find that the head circumference is really, really low, this is an alarm, and you actually need to send the child forward to a pediatrician or to a specialist at the earliest possible, because you could be looking at something serious. Now, these are the equipments for you use an infantometer, that is you make the child lie down, that is the one in the middle, and The one that you can see on the right hand side is the stadiometer. So the stadiometer is the instrument on which we measure height for children more than 2 years of age. And you can see there is always a step ladder there. So if there is an older child coming to us, many of our researchers are actually shorter than them, and we need them to get onto a stool and then measure. So our step ladder is always standing next to our stadiometer. The weight scales are also of various types. You can get a very, very basic one like the bathroom balance. Then you have bean balances, you have electronic scales, and you have scales like, the spring machines which you need to use in field conditions. In very young children, actually, electronic scales are very useful because often, the least count is quite low, and you might, especially when a child is sick or you're doing some nutrition intervention, you might want to see differences even in 100 or 200 grams, which you will not be able to see on the other weight scales which are not so precise. So after having measured, it's necessary to compare the measurements with standards or reference values. So your children whom you're measuring need to have growth charts. Most growth charts, whether you take the WHO or the Indian Academy of Pediatrics, are available free of cost on their websites. They are freely downloadable. It's important at all ages, though here we are talking about the first 1,000 days. The children don't stop growing. In girls, till they've stopped their periods, and 1 year afterwards. In boys, till they've stopped shaving, still they've started shaving. So boys might grow till 16 to 18 years and girls till 15 years. And at least a yearly measurement in older children is important. So if you want to, so you have measured a child, but now you need to know how to actually interpret that measurement. So because we are looking at the first 1,000 days or under 5 years of age, we need to use the WHO growth charts. So the WHO growth charts were introduced in 2006. This is the WHO MGRS study, which was a worldwide study done in 8 countries. And you have lots of growth charts in the WHO charts. I will come to that a bit later, but you can actually download all the charts from the WHO websites. So this is the boys chart that you can see here. On the x-axis, you have age, and on the y-axis, you have height. I'll show you how to plot them if you have not done this before. So WHO has lots and lots of charts. You have length or height for age, you have weight for age, weight for length, weight for height. You have BMI, because we generally use BMI after 2 years. You have head circumference and arm circumference. And then you have many more like the subscapular, the triceps, the motor development, weight, height, velocity, and the head circumference velocity. So these are not used those commonly. I would say the one on the left are used much more commonly. So let me get this up and get a sip of water. So what are the components of a growth chart? So like we said, x-axis, here is the age. In the weight for height chart, you have slightly different parameters. Each year is divided as 12 months, and y-axis is the height here, or weight in kg, or it may be BMI. And the background of the chart is a grid, so you can plot it easily. Blue is boys and pink is girls, as is the tradition. So what are the important concepts when you're plotting the growth charts? I will get all this up. So please put small dots. Now you will notice, like I'll point this out to you in one of the cases that I'll be showing, that particularly in the first few years, you actually measure children many times. So what actually happens is that you need to plot the child many times, and you could get one dot into the other and get yourself and the child and parent into trouble. So put dots and not blobs. Please write the patient's name or the child's name, date of birth on the chart. And if you possibly can, also put the parent's height. Then you go on to plot the height and weight, or the weight for height, depending upon what you're looking for. Now, why do you need parents' height? You need parents' height, especially in older children, because, you cannot compare the height of a child whose father is 6 feet and mom is 6 feet 7 to the height of a child whose father is 5 feet 6 and the mom is 5 feet. So naturally, the second child will be shorter from the beginning and may stay short throughout than the other child. Now, how do you actually look at the growth curve? Now, this is a cartoon. So once again, age on the x-axis, there is height on the y-axis. So we have drawn some lines to show you. So generally, so all these multiple lines are called as the centiles. So if you see that a child is staying on the same centile, which is what normally happens, you can just leave the child in normal situation. If you find that the child is very underweight and is keeping on his own centile, then obviously you would be worried. But if the child is, say, on the 50th centile, which is the mean for that population, and going along the 50th centile, you would be happy. If the child is on the 25th centile, what does a centile mean? You make 100 people stand in a row. The shortest is 0, the tallest is 100. 25th centile is the 25th person. So if a child is on 25th centile and continues on that, I still wouldn't worry, because maybe that's where his parents are. That is where his height is going to lie. What happens now? Look at the picture on the right. So the good says it either goes slightly upward or sticks to its own centile. If your curve goes down or remains flat, then obviously the child is not growing in the way you would like the child to grow. So this is certainly something to worry about. So this is a little boy. I've just plotted the chart here for you. You can see he's 3 years old. So on 3 years old, the lowest three lines are the weight, the one in the middle is the head circumference, and the one on top is the height. So as you can see, the height of the child here is 82 centimeters, weight is 10 kilos, and he's 3 years old. But if you see the lowest two, so look at the top lines, the top four lines. So those are the height lines, and the lowest red line of the four lines is the first centile. So the first centile, if the child is under the first centile, you have to be really, really worried. And this is where our little one here is. So whoever the healthcare professional is has to take immediate cognizance, because this child is really, really short. So what are the cutoffs that we use for children under 2 years of age? So for moderate underweight, you use, or moderate stunting, you use a cutoff of -2 Z score, which is around the third centile. So just to remind you, this would be the third person in the 0 to 100 people standing in a line. So your child is under the first three people in the population. So that means the child is short. So you need to be worried. But if it is -3 Z score, which is under the first centile, that means the child is shorter than the shortest child. That is, the child is on the 0. So there it is severe underweight or severely stunted, and then you really have to worry. So a lot of you are nutritionists, so you know SAM and MAM. MAM is if your weight for height. See, remember I said some time ago, it is a sensitive indicator. So if your weight for height for a little one is between -2 to -3 SD, which means between the first to third centile, which means between the two lower red lines on your growth charts, then it's moderate malnutrition. You have to kick into action. You know something is very, very wrong. And if the child is under the third centile, that is less than -3 SD, then you are in severe trouble. So the reason that I actually showed you the curves earlier on is that I myself have always felt that don't wait, you see a child going down, you have to act, you have to find out what is wrong. You cannot wait for a child to actually go under -2 or go under -3 and then start, because it is always very hard to pull a child back from that state. So if you see that a child's growth curve is flattening off, that is the time to act, and act at the earliest. So there is one small word of caution. So in the WHO growth standards, when they were made, there were also Indian children in that. But the Indian children came from Delhi. And in 1998, the income of the children, of the children's parents was 60,000 a month, so long ago in 1998. So these were children from very, very well-off families. So what is happening is, in many developing countries, including in India, a lot of children are actually diagnosed as stunted or short or wasted, as underweight. because we are essentially a little bit smaller than the Western population. So this is something that we should keep in mind when we are actually plotting a growth chart. And that is why often multiple readings are much better than a single reading. That is, of course, if the patient is kind enough to come to you multiple times. So we actually did a study back in 2010. I mean, we published it in 2010, where we looked at affluent Indian preschool children and we compared them with the WHO growth charts. And what we found is that now look at the numbers. So this is actually all negative. So you can see these are the mean Z scores of well-off children. And you can see that the mean height Z score was minus 0.75, mean weight Z score was almost minus 0.6, mean BMI was minus 0.2, weight for height was almost minus 0.3. So essentially, our well-off children are also short on the WHO growth chart. So this is something that we should remember. Another thing we find in our practices is that mothers and parents in general get very disheartened if they see that, oh, we are trying our best, but our child is still on the third percentile. So that can also be an issue. But the government of India has actually taken on the WHO charts, as has the Indian Academy of Pediatrics. And the reason why this has been done is that for the World Health Organization to compare prevalence of malnutrition over various countries, you have to use the same growth charts. If we use Indian charts, the Thai use Thai, the Japanese use Japanese, then you never know, because the starting point is different, you don't know what is the real prevalence of malnutrition. That is why all of us have started using the WHO growth charts. Now, I have spoken of the height, weight, and weight for height. So just a little bit on the mid-arm circumference. This is done in children generally from 6 months to 59 months of age. And you can use the UNICEF tapes to do that. And if the child is under 115 centimeters or 115 millimeters, I'm sorry, or 11.5 centimeters, then the child is supposed to be malnourished, have severe acute malnutrition or SAM. So like you can diagnose SAM by weight for height, you can also do it by MUAC, which is a quick technique, especially in the field or for population-based studies. Similarly, for head circumference at various ages, like I said, we don't do it after 3 years, but generally till 3 years of age, if you have to measure, this is the way you measure it, like it is being seen in the picture. I'd like to just draw your attention to two. I mean, these slides are not really a part of the WHO standards, but apart from the weight or height that the child has today, or you're looking at multiple readings, you need to be aware of the height velocity. So say you measure a child at 1 year when the child is 75 centimeters, and then you again measure him at 2 years when he's 90 centimeters. So his growth velocity from 1 to 2 years of age is 15 centimeters. So sometimes you need to look at the velocity also. So now we know that a child grows 25 centimeters in the first year of life. Say so in 6 months, say from 0 to 6 months, if a child's growth velocity is only 5 to 7 centimeters, something is wrong somewhere. So we also actually look at height velocity and weight velocity. So if a child is gaining very little weight over a period of time rather than what his weight is today, is also important. So of course, this is slightly for your older practitioners, but it is something that we should keep in mind, that velocity is also something we need to look at. Now, weight velocity is something that we look at a lot nowadays in obesity as well. Remember that the prevalence of obesity in urban areas is going up. Almost 1 in 4 or 1 in 5 children is overweight or obese. So we need to look at weight velocity as well. Now, how often do you measure? So I have actually put down the measurements as per the government, which is the Anganwadi workers, and I have put it down in the next slide according to the Indian Academy of Pediatrics, which is what we follow. So newborns and children from birth to 1 month is practically you need to see them weekly, 1 month to 3 years every month, and from 3 to 5 years at every 3 months. What do we do in IAP? So, in Indian Academy of Pediatrics, we actually do it at all immunization visits. So, initially at birth, then at 6 weeks, 10 weeks, 14 weeks, 6 months, 9 months, 12 months, 15 and 18 months. So, every time, so as you and I know, taking a little baby with all his or her paraphernalia to the doctor just to be measured is very, very hard. So, uh, weighing at the time of immunization is usually a very good practice, and what we normally say, you should also take this opportunity to counsel for nutrition and other things in a child, because anyway the mom has come to you with the baby. So we normally do it at all the immunization visits. One very, very critical thing is that normally growing babies should not be made weighed more than once per fortnight. That is, once should not be weighed more than once in 15 days under 6 months of age, because this really, really escalates the mother's anxiety. Remember that WHO has said that only breastfeeding till first 6 months of life. And if you actually keep weighing the baby all the time and say, oh, he's 20 grams less or he's 50 grams less, it makes a mother very, very nervous, because she is the only source of nutrition for the baby. And you know what our Indian families are like. So don't weigh the baby too frequently. And after 18 months, measurements are generally to be taken every 6 months. So for it is recommended that the height, weight, and head circumference be measured regularly up to 3 years of age. After 3 years, we don't generally take the head circumference. But what we find is that many people stop taking the weight and height after 5 years of age. But even afterwards, once in 6 months, if not possible, once a year at least, a recording should be made, because a second growth spurt happens in the pubertal years, which is 9 to 14 years in girls, and around 11 to 12 years to 16, 17 years in boys. So at least once a year later is important. I know it is not important here because we are talking about the first 1,000 days, but it gives me an opportunity to tell you about this. Now, this is just, putting it all together for the Indian Academy of Pediatrics. This is what we do. And like I said, we don't measure head circumference after 3 years of age. This just emphasizes how important the first 2 or 3 years are. Now, how do you do all this? Do you sit with your calculator? Do you, after you have measured, the child is crying away, the mother is wants to go back home? What do you do? So there are lots of softwares available for where you can just punch in the numbers and you'll have the Z scores, percentiles. The child will also be classified for you. So the Anthro and the Anthro Plus are the softwares that the WHO has come up with. You can just punch in the numbers, just download the software, get used to it, and you can either use Anthro, which is up to 5 years, or Anthro Plus, which is up to 18 years of age for assessment of height. From 5 to 18 years, we actually advise that you use Indian charts. So the Indian Academy of Pediatrics also has a software of its own, so you can use that as well. Otherwise, you can use the WHO software. And this is what it will give you. It will give you height for age, weight for height, BMI for age, head circumference, MUAC. So it's a very, very good software. We've been using it for a very long time. So that's the Anthroplus, which gives you measurements or interpretation till 19 years. And it actually gives you interpretation. It tells you where the child lies. Now coming to the cases, putting it all together, how do you use all this, stuff that I have been telling you about? So we have a little girl here whose name is S. She delivered to a primigravida mother. Primigravida is somebody who's had the first baby. She has had a normal delivery. She was a Bonnie 3.2 kg. Her length was 49 centimeters and the head circumference was 34.5. So if I were to look at this as a pediatrician, all this is bang normal. So what would I do? This is how I would plot. I would plot the weight, I would plot the head circumference, and I would plot the height. Now, one of the things with the WHO charts is that, or any chart under 5 years old, is that because the charts, because the numbers are so close together, it sometimes is a little hard to interpret. But anyway, so roughly this is on the third centile for weight. The head circumference is on the 50th centile, as is the length. Then what happened? So she came back on 7th day and her weight was 3 kg, which was less than birth weight. They were in a panic. What is happening? So uh, In the first few days of life, a healthy baby also loses some weight, which is normally regained by the 10th day of life. She came back again on 15th day. They said it's loose stools. The weight at that time was 3.1 kg. She had not as yet regained the birth weight. You might remember it was 3.2 kg. So now we plot all the parameters. Now, so to remind you, she was born at 3.2 kgs. Then she came to 3.1 kg on 15 days of life. So here we plot it. I have, blown this up a little bit. So now you can see that the weight was almost on the 50th centile, which has come down a little. You can see this little line. So the baby has lost a bit of weight. What did we do? We said wait and watch. So they were complaining of loose stools, but they were actually breast milk stools. You may be knowing a completely breastfed baby has golden yellow colored stools, and a baby might also pass stools 20 to 25 times a day, which may be completely normal. As far as the baby is healthy, drinking milk, gaining weight, we don't have to worry. So what happened? So we reassured the mother, sent her back. We assessed the feeding. We said, you're doing a very good job. There's nothing wrong with your baby. She came for vaccinations at 6 weeks, 4 kg, 10 weeks, practically 5, 5.5, 6.2, and 7 kg. So this is how she looked. So now you can see that her weight was going absolutely fine. In fact, it has gone up a little bit, and through use of growth charts, we could actually reassure the mother. We ourselves were reassured that all is well and no investigations were done. There was no anxiety after that on the part of the mother or us, and any unnecessary treatment was avoided. So, like I said to you, confirming normality is also very, very important. Many times you just want to know, or a parent just wants to know that his or her child is normal. Now, in the second case, we have an 8-month-old girl here who was brought with a concern of not growing well. So weight is 5 kg, which does look a bit worrying. Then her length is 63 centimeters, so which also could be a little less. The head circumference at 41.5 is probably okay. So if you look at such numbers, it's extremely confusing. So you have to go to the growth chart. Now let's plot her. So this is the weight. As you can see, it's a little below the third centile or even the first centile. The head circumference is just a little bit above, and the height also seems to be on the third centile. So if I looked at it like this, I would think that, okay, everything on third centile may be just okay. Maybe I just need to send the child back, reassure, check what she's eating, whether she started, weaning, which should start at 7th month. But I thought, should I do a weight for height? Would that be better? So wisely, I went ahead and did a weight for height. And what I found that now in this chart, the weight is on the x-axis. The height is on the x-axis. The weight is on the y-axis. And as you can see, she's under the first centile for weight for height. So her weight for her height is very low. So this is malnutrition or it's a chronic disease, right? So weight for length is below the third. In fact, it is below the first centile. Then we were lucky enough to find earlier 2 readings, and this is how they go. Let me bring all this up. Okay, here we are. So I don't know why, but many times people just hide their earlier readings, will not tell you that they've gone to a doctor before this. This is not in their interest, but this is what people tend to do. And now if we had the readings in the beginning itself, you can see, if you look at the lowest graph, you will see that the child is actually falling off. So the weight is reducing. The height and head circumference seems to be doing okay. So this is, the child is short because the child is on the third or first centile, but the weight for height is on the first or third centile. So this could be nutritional. So this could be wasting, malnutrition, or it could be some kind of chronic disease. Remember, in a child, from a growth chart, you can actually diagnose anything from tuberculosis or, a chronic disease in a child to a child being unhappy. Even unhappy children don't grow. So, the growth charts can be used for many, many uh, things when you are actually dealing with children. Now, in this case 3, you have a baby boy here who presented at 4 months of age for lack of head control. Now, you know that most children at 3 months of age, they will actually start head holding, sorry, around 15 days here or there. His weight was 4.8 kg, length was 56 centimeters, which to me seems a little less because at birth a child is normally 50 centimeters, and the head circumference was 39.5. So let's plot the child. So this is where he was. So if you look at the lowest one, so his weight is a little below the first centile. So yes, he's light. If you look at the head circumference, it's the third centile. But look at the height. The height is way below the first centile. So when there is discordance in these parameters, we saw in one of the earlier ones that all of them were kind of sitting on the third or first centile. But here you can see that the height seems to be more affected. In this case, something else is going on. So the weight for age was less than first centile. The length for age, you saw that the child was really short. So he was underweight, he stunted, but the head circumference was okay on the third centile. So luckily, once again, they produced the 2 earlier measurements. At birth was 3.1 kg, 50 centimeters. You can see both parameters bang normal. At 2 months, 3.6 kg, which is also okay. 54.5, maybe falling behind a little bit. Head circumference is okay. But look, so this is the strength of multiple readings. Now you can see that the height is falling off. So this doesn't actually mean that the child is getting short. What it means is that the child is short for his peers. That is why you need reference data or growth charts. So you can see that the weight is still a little bit low. The head circumference is going down a little bit, but what is going down most is the height. So this height now is well below the first centile, which is when we have seen the child at 4 months of age. So then again, we plotted the child on the weight for height. Now you can see the weight for height is on the 50th centile. Let me remind you of the second case where the child had malnutrition and you saw that the weight for height was under the first centile. So the weight was very low for the height. Here the weight is okay for the height. It is on the mean value or the median value. So this is not malnutrition. So here you can see what is most affected is the height. Generally, when the height is very affected, you're looking at something more serious than, so I'm not implying that malnutrition is not serious, but malnutrition is also extremely serious. But here you're looking at something else. So this child is not malnourished. So the weight for height is on the 50th centile, and this child actually did not have protein energy malnutrition. The length was affected. So we found that this child had a thyroid disorder. So for hypothyroidism, now screening is available at birth, and please, you must get it done for all babies because this is a preventable cause of mental retardation. So if you actually start thyroxine at birth in a baby who's picked up, and in the newborn screening, the baby can be completely normal. So this child, unfortunately, we picked up at 4 months of age and he had already fallen back a little. You may recall his first symptom was lack of head control. So the development was already falling back. Now, in the case 4, this is a 2.6-year-old girl. So they presented with a poor growth. Mom and dad were very worried. Weight is 7.2, which seems really low. Height is 77, which also seems low. But then you have this very important piece of data, which is that the baby was born full term, but at 1.5 kg. The length was 43 centimeters and the head circumference was 32. So you are dealing with a small for gestational age baby. So for whatever reasons, this baby's growth was compromised in the mother's womb. So this baby was hit by the first 270 of the 1,000 days. And that is why the growth of these children often remains quite poor. So you can see that this is the growth chart of this child born small for gestational age, and she has remained uh, underweight Head circumference is okay, which is normally what happens. The head circumference is preserved, and you can see that the height is well below the first centile. So these children often need help for their growth. So if there is a child who is actually less than 2.5 kilos, especially under 2 kilos of age weight at birth, then the chance that the child will have growth failure is there. And as you can see here, from the birth weight and from this chart, you can tell that this is actually what we call a small for gestational age sequelae. So this has resulted because the child was born small for gestational age. In case 5, you have a 4-year-old girl who presented with excessive weight gain. Now, this is the other end of the spectrum. Her birth weight was 2.8, so which falls within the reference range. She wasn't SGA, she wasn't too big. Length was 49, which is normal, and head circumference was 35, which is also normal. So we've already plotted them here. You can see that the head circumference is anywhere, because the earlier years and in the earlier times it comes together a little bit. So but it is between the first third centile and the 50th centile. You can see, sorry, that's the weight. The head circumference is on the 50th, and you can see that the height is also roughly on the 50th centile. So this doesn't look like you have anything to worry about. In the first year, it was very difficult to feed her and she was slow to develop. So this should ring alarm bells that something is going wrong. At 12 months, her weight was 6.5 kgs, which is not too much. Length was 72, which is normal, and head circumference was 45. So this is where she was. So lowest is weight, doing okay. Head circumference, doing okay. Height, well, I'd start worrying a little bit. She seems to be falling off a little bit. Kept following up with us at 18 months. There was a sudden increase in her appetite. The baby, who was very hard to feed, suddenly started eating and eating. At 24 months, height was 85. This definitely looks worrying. Weight was 11. At 48 months, 92 and 22 kgs. At 48 months, a 4-year-old 22 is quite a lot. So now let's see where she stands. So this is what it started looking like. You can see that her weight is going up. The lowermost graph is the weight. Head circumference doing okay. But did you see what is happening with the height? The height seems to be dropping off. So the next thing is, of course, to do a weight for height. So this is what we did. And this is how we plotted it. And that's what has happened. So you can see the steep rise in the weight for height. And actually, in very young children, managing their appetite is very hard. So this was a child with what we call as the Prader-Willi syndrome. And these children tend to eat a lot. And in such a small child, there is no explaining to the child that she's going to be overweight, or you don't want her to gain too much weight, because and the child keeps crying. So the parents tend to feed the child, and this is what happens. But this is syndromic. This is not a normal child. So these were the 5 cases and the importance of growth monitoring. So in the last few minutes, I'll just sum up. So I hope I've stressed on you enough that growth is very rapid in the first 1,000 days, first few years of life, particularly 3, most importantly in the first 2 years of life. Remember, you grow fast, but you fall off fast as well. What is lost in infancy cannot be regained. Many times, healthcare workers tend to tell parents that, oh, he will grow as he grows into puberty. What he has lost when he was little, he cannot gain in puberty. Please remember that. Your measurement tools and techniques need to be good and accurate. You have no face to show if a child's height has reduced, though it can happen with the weight. And calibration of your scales is very important. If your weight scale starts at 2 kgs, remember you're going to get a wrong weight. So calibration of weight and height scales are very important. Meticulously charting growth is very important. It is very inexpensive, and you can also train somebody to do this. I find that people do it fairly well if you train someone well and keep training them again and again. If growth falters, please take immediate action. This is, I think, my most important message, that take immediate action if growth falters. Delays can result in irretrievable loss. Remember, 10 centimeters lost in the first year of life cannot be regained later in life. WHO has published growth standards in 2006, which we use for children under 5 years. But data from many developing countries, including our own studies, shows that you may overdiagnose stunting, and I've eaten up the wasting, but it says wasting over there. Thus, be careful when you interpret data. Head and mid-arm circumference are also parameters which are measured, more so the mid-arm in the population-based surveys. If the head circumference is low, it is an alarm. You have to refer the child quickly. If you look at, there are softwares which can help you do this, but you will have to measure and plot or measure and punch in the numbers, and then the softwares will do the rest. Growth monitoring is also vital for the prevention of obesity. Remember, a little one who grows to at 2 years of age to be 25 kilos is going to be very hard to deal with later. Extreme short stature is more likely to have a pathological cause. You saw the little one with the hypothyroid case. So a child whose height is very, very less is likely to have more issues than just nutritional. Diagnostic, and remember that diagnostic and therapeutic avenues for childhood growth disorders are ever expanding. New drugs are coming in every day. So if you find a child who's very short, do refer the child. Don't say that the child will grow as he grows older, because often it does not happen. Also, to sum up, what do you achieve through growth monitoring? You can pick up growth abnormalities early. You can pick up underweight, stunting, wasting, overweight, and obesity. You can reassure the parent and healthcare worker. And diagnosis and monitoring of nutritional and endocrine and many other childhood disorders. In fact, when we are treating a child, many times the only thing that we do is plot a growth chart. If on the growth chart the child is doing well, often you know that the treatment is going well. So please always chart and monitor growth. Thank you so much. Thanks.
Thank you, ma'am. You have taken us through the journey of anthropometric measurement assessment and its importance, especially in the child's first 2 years of life. You have also given us an insight of using WHO Anthro and IAP Anthro softwares. I think all the participants will agree with me that you have made the presentations very clear and informative with your case study presentation. To say that growth monitoring is very important in the first 2 years of life to avoid stunting, wasting, obesity, etc. Thank you very much, ma'am.
Thank you.
Can we take up some questions?
Sure.
Yes. Okay. First question.
Yeah.
If a baby born at normal birth weight doesn't reach the birth weight even after a month, is it a concern?
Yes, I would say it's a concern. If a baby is born normal, so like I said, generally the birth weight is regained by the 10th day of life. So if the baby doesn't regain the birth weight by the 1 month, definitely you have to actually take the baby to your pediatrician, and it is a matter of concern. So either the feeding is too less or there is something else that is wrong with the baby. So certainly that needs to be looked into, certainly. So by 10th day, I would say even 15th day is okay, but till end of first month of life, I would say the birth weight should definitely have been regained. Definitely.
Thank you, ma'am. Which one is better criteria to identify a child with SAM, MUAC, or WHZ score? There are multitude contradictory research on this topic.
Yeah. So what you say is right. So if I was actually doing it in my clinic, or anywhere in a clinic of a healthcare worker or a nutritionist clinic, I would always use weight for height. It is a much better indicator. If it was a population based survey, I would use MUAC. Now there is something more also to this argument, that it also depends on like where you're doing it. Now in some places, there are no so let me just go back one step and say, if it was a clinic based, I would do weight for height. I would know how to do the height weight. I would have equipment which is calibrated and correct, so I would use that. In a very busy OPD, which is where 100 150 children are seen every day, I might consider the mid-arm circumference because at that point of time, I myself or one of my assistants will not be able to do weight for height, and you might get it wrong. So when you rapidly need an assessment of nutrition, then MUAC is a better indicator. And of course, in population-based studies, it is a good indicator. Now, with MUAC, many people have said that if you actually keep a cutoff of 11.5, which is what the WHO has said, then it is a very low cutoff. There are many papers which have said that the cutoff needs to be raised. So less number of children are actually picked up as malnourished by MUAC than they are by weight for height. So I would say if, and another thing is this 11.5 cutoff is constant between 6 months to say 5 years of age. We have just seen how much children grow. So, having the same cutoff doesn't, I don't think it is that scientific, but in a population based survey, it is fine. So, clinic, weight for height, population-based survey, less experienced people who are taking the measurements, I would do MUSC.
Okay, ma'am. Thank you for that. At what age generally catch up growth happens, especially for a child born SGA?
Right. So, if you look at our textbooks, they say 2 years. So, catch-up growth will happen by 2 years of age. But our experience with Indian children is that they often even catch up by 4 or 5 years of age. So, most of the times we wait till around 4 years. But even here, now see, in each of these situations, there is a bit of a rider. So, if you have a little one who's really, really short, I wouldn't wait, way below the first centile, I wouldn't wait because the catch up is not going to happen that much. But if it was a child who is just a little bit below, the child might catch up. So my answer is, if severely affected, don't wait. Generally catch up by 2 years. And in Indian children, we generally wait till 3 to 4 years. Most children catch up by 3 to 4. If they don't catch up by 4 years, then I would say they are less likely to catch up. Less likely to catch up.
Okay, ma'am. Thank you. MUAC measurements can be useful till which ages?
So MUAC measurements are useful as a SAM to diagnose SAM-MAM till 5 years of age. As we know, it has been given by WHO. But there are also special situations in which you can actually use MUAC in older children, even in adults, it has been used. Now, one thing for that is, of course, population based. When you are out in the community, taking mid-arm circumferences is much easier. That is one thing. Second, special circumstances like in amputees who can't stand up, or in a child who is unconscious, or sometimes in children with cancer where the if there is a large tumor, then the weight for height is not reliable. So in such special situations, you can do MUSC in older children. So in fact, right now we are working on a paper for that, and we should, maybe in a year's time, we should have it out.
Okay, ma'am. Thank you. Are intergrowth charts more reliable?
So the intergrowth talks about the intrauterine growth
Yes.
of children. And then again, like the WHO, there is a lot of, um, force and against it. So, but at this point of time, they are the only charts available for intrauterine growth, which we can use. Now, but if you look at the intergrowth chart paper, they have actually, removed women who were 145 centimeter, less than, it's either 145 or 150. So a lot of our women are quite short as well. So a lot of our children are actually smaller than what the intergrowth shows. So it's exactly like the WHO charts, but at this point of time, we have nothing else available. So we use the intergrowth when we have to. Yes.
This is an interesting question.
Uh-huh.
Usually, first child is shorter than the second in most cases. Some observation they have done. So they have asked this question. What is your answer, ma'am?
No. I have not seen anything like this, that the first child is shorter than the other. Second one, I mean, there are, you could, there, I don't think there is any scientific reason behind this. if you look at it this way, in the first child, the mother is a preemie, has less experience, but she has only herself and the baby inside to look after, often tends to put on more weight. When she has the second child, she does more running around, but then she is more experienced. But there is no scientific data around this, that the first child is shorter than the second. There's no scientific data. No, I haven't seen it ever.
Okay, thank you. Do we have any Indian growth references database for infants 0 to 2 years of age?
So there are earlier charts. So first time the ICMR came up with charts in 0 to 2 years. After that, there is a study by Dr. Agarwal from the north of India. So there is data from 0 to 2 years from there. We ourselves have done charts, but actually the IAP has not put it out because the World Health Organization has actually said that everybody should use the World Health Organization charts. So though we are working on so much growth data, we don't particularly collect data in that age group because we've been told not to make charts in that age group. So largely no, I would say you'll have to use the WHO data. The other data is pretty old, and as you know, because of this, because of the nutrition transition, there is an increase in weight as well as an increase in length, and it may not be right to compare it with older references. But there are no contemporary 0 to 2 year old reference charts because the government has said use WHO charts.
Okay. Thank you, ma'am. When compared to term babies and preterm babies, what are the common anthropometric and biochemical changes we commonly see?
Sorry, I didn't get your question. So in the term and preterm,
Yes,
comparison between both.
compared to term, yes, ma'am. Yes.
Right. So actually what happens is, if you look at the anthropometry, now in the preterm, it will depend upon how preterm the baby is. If it's just a couple of weeks, you may not see much difference. But if you have a baby which is very preterm, so what actually happens is, in the last 3 months, as the last trimester, there's the maximum gain in weight. So the baby gains maximum weight in the last trimester of pregnancy. So both the length and the weight are affected in preterm babies. But if it's a preterm and not a growth retarded baby, you know the difference, the SGA, IUGR, or the preterm. If it's just the baby has come early but well formed, has not had any intrauterine insult, then what we tend to do is either use preterm charts, which is we use a chart called a Fenton chart, but I know there is something else also available. And um, we also correct for term. So if a baby has been actually born 6 weeks preterm, then we actually, so if you have a baby who's today 12 weeks old, has come to me, then I would actually measure that baby as at 6 weeks. So we correct for that. So generally, if there are no otherwise intrauterine insults, then you just need to go back that much. And we continue this correction till the baby is or the infant is 2 years old. After that, prematurity correction, we stop. Now, this is, I'm talking about a healthy preterm. Now, if the preterm gets sick, which unfortunately is likely to happen more with preterm babies, or is IUGR, then the set of problems is completely different and the baby may not grow well. But if the baby is a healthy preterm and not too preterm, then you just need to correct till 2 years of age and you consider those many days less. If it's 6 weeks preterm, you consider 6 weeks less when you actually plot the baby.
Oh, thank you, ma'am. Can we manage the babies with delayed growth with diet alone?
Depending upon what the reason for the delayed growth is. So there are innumerable number of reasons for delay in growth. It could be an endocrine reason, it could be a developmental reason. If it is malnutrition, yes, you can. If it is other than malnutrition, you can't. You can't.
Okay.
Generally, and when the height is more affected than the weight, then don't wait. Generally, it's something else. You can't do it with nutrition alone. Nutrition is important for everything, but you can't do it with nutrition alone.
Alone, we can't take it up. Okay. Thank you, ma'am. Is weight for length affected by the genetic makeup of a child?
So both weight and length are affected. Weight for length can also be affected by the genetic makeup. That's why I said to you in the beginning that if possible, put down the parent's height. So the height is more representative of the genetic potential than the weight is. As you know, the weight or BMI can be more environmental, but yes, height has a lot of genetic, linkages. But there are also these things, like if be careful when you're looking at very short parents and slightly tall children, because sometimes the parents have not, gained the right height because they didn't get good nutrition when they were small. But if you look at the big picture, yes, height is more affected by genes than weight is. Weight is more affected by environment, but weight for height may be affected by your genetic makeup, definitely.
Okay, ma'am. Thank you very much. If a baby loses weight or if there is much fluctuations after first 1,000 days, is it a concern?
Yes, always a concern. If a baby loses weight, it's still a concern. But how much weight is lost is what you need to see. So
Oh,
generally anything between, which is more than 5% of the earlier weight, we would worry about that. We would worry.
uh, does top feed bring rapid weight increase and cause a disruption in growth chart? There is a question.
So it's a long question. So it's a long answer, sorry. So
Yeah.
as you know, up to first 6 months, we advise strict breastfeeding because it has more than nutrition. If a lady, for whatever reasons, health reasons, whatever, is not able to breastfeed, and she uses buffalo milk or cow's milk, anything, so then it is likely that the weight might go up more because especially in the buffalo milk, the fat is higher than in cow's milk or human milk. Human milk has much lower fat. Also, the what we call the solute load is much higher, so the baby tends to retain more water, so the baby actually weighs more when the baby is on top feed. So if at all you were to give top feeds, I would say it is best to resort to, and when you're sure that you can't, the mom cannot breastfeed, then you would have to resort to something like nan or special baby milks meant for babies. So
Okay.
the second part of this is that in the first CDC growth charts actually were made on babies who were top fed. And those babies were huge. And our babies were tiny in front of them because we were always, A, we are a bit smaller, and B, we are also, we were mainly breastfed. So then they actually changed that. So that is why the WHO growth charts came in, where all the babies in the WHO growth charts are breastfed. And that's where their weights are lesser than the CDC charts because these are breastfed babies. It's a long
Okay.
answer to the
Yeah,
question.
it is a very long answer. Thank you, ma'am.
Sorry.
If the next question, ma'am, if the pregnant woman is suffering from hypothyroidism, would that influence growth of the baby in the womb?
Yes, if she is uncontrolled, it would. So the baby doesn't actually make thyroxine. It comes from the mother to the baby. So if the mom doesn't have enough thyroid hormone around, she's not going to give it to the baby. And yes, the baby will be affected. So any lady who actually is a hypothyroid and wants to get pregnant should have normal levels of thyroid hormones before when they start trying for a pregnancy, and throughout pregnancy she should be under the monitoring of a person who understands thyroid disease well, which means an endocrinologist plus a gynecologist or a gynecological endocrinologist.
Okay, ma'am. Thank you. What assessment tool you would suggest in pediatric critical care unit, especially if a child is on enteral nutrition?
So you can't really do you know weight for height, or doing weight is also hard in such babies. Of course, if you can do weight, because the length is not going to change that drastically. So if you can do weight, you should do weight. Otherwise, you can do mid arm. The other thing you can also do is things like the tricep skin fold thickness, because you can't do other things in such small, I mean, now if you are talking about the 1,000 days, then in such a small child doing anything else is very hard. Is very hard. So one of these three, either you do the weight, you do the mid arm, or you do the triceps.
Okay. Thank you, ma'am. One very interesting question.
Mhm.
Is the bone age calculation applicable to predict growth of children?
Yes, it is. So
Somebody must have heard you before, I think.
looks like I, I I was just thinking if I forgot to take out the slide of bone age. But
Yeah.
so yes, we do bone ages. So when a child is actually very short, so what the bone age tells you is the skeletal maturity of a child. So to give you an example, when a girl actually starts her breast development or becomes, properly develops, has her proper development done, pubertal development done, then her bone age advances a lot. So yes, bone age can be actually, you can predict height according to bone age, and but not under 2 years. Under 2 years, bone age is very unreliable. So generally, we do it at older ages. But yes, it can be done. It can be done.
Ma'am, there are a lot of questions posted. Can we take two or three questions more?
Yes, yes, I'm okay. Like you said, five. Absolutely, you can, maybe you can pick and choose a little from them. So another 15 minutes is absolutely fine. No problem.
Okay, thank you so much, ma'am. Then we can.
Okay.
In case of 6 years weight, is 17 kg as compared to age, what will be the cause? I don't know. I mean,
I
this,
have no idea what this means.
yeah, that's when it's not. Can an infant born from a mother of low pre-pregnancy BMI have normal or higher birth weight?
Yes, normal birth weight, yes. So, in fact, in India, many women have low BMI before they are, before they get pregnant, and they have amazingly normal babies. So, there is some way in which the body actually partitions energy and it is diverted towards the baby. I know I've seen in our studies, very thin women also have normal sized babies. So, yes, it is possible. She can have a normal size. A large baby, I doubt, but a normal size over 2.5 kgs, definitely. Definitely.
Okay, okay. Thank you, ma'am. Does an extended breech position baby have any effect on growth?
So, what can happen with a breech is, so normally what happens is the head comes out first, as you know. And as the baby's head is slowly coming out, the pressure on the head is slowly released. With every contraction, a little bit comes out, little bit comes out, and then the child slips out. In a breech, what happens is the shoulder, which is the broadest part, comes out first. So the baby's head slips out very quickly. And what is likely to happen is that some delicate parts of the brain, like the pituitary, they can have some, there can be actually, I don't know what exactly it is, but I think it's a hemorrhage in the pituitary, because of which the pituitary functioning can go down. So in earlier times, when there were no cesarean sections available, because of the sudden decompression of the head in a breech delivery, we used to see a lot of growth hormone deficiency. But luckily, because of the cesarean sections, that has gone down. But yes, it can happen. It can happen. We have
Okay,
seen many patients.
okay, ma'am. Thank you. Does amniotic fluid volume play a vital role on baby's height and weight or growth and development later?
So the thing is that amniotic fluid volume is reflective of the mother's health also. So it can be low in places where the mother has some problem or the baby has a renal problem. So I would say, rather than look at it whether the growth is will be normal in these children, the reason for the low amniotic fluid will actually guide this. So, a renal issue in the baby is likely to be there because of the low amniotic, is likely to cause the low amniotic fluid. And then obviously, if the child has a problem with his or her kidneys, then the growth will also be affected. So I would look at the reason for the low amniotic fluid. That is more important than whether low amniotic fluid affects growth or not. The other way around.
Okay, thank you, ma'am. If the mother had a history of PCOS,
Huh.
will it affect the fetus or after the baby is born?
So generally, no. Depending upon how severe the PCOS is, the whether the mother has hyperinsulinemia, if she develops diabetes during pregnancy, then obviously she will have to be treated like that. But otherwise, in the newborn, you should not see too much unless there is insulin resistance, and high blood sugars or hypertension in the mother. But what has been seen is girls of moms who are PCOS are more likely to get PCOS as they grow older, and sometimes it happens at a younger age than the mother got it. So that is there. So PCOS may be slightly more common in daughters of moms who have had PCOS, not because of the pregnancy, but because she had PCOS, the girl is likely to have PCOS.
Okay, ma'am. Thank you. Does the maternal diet affect the height and weight of the baby?
So yes, it does. So you need to, there are guidelines on this. So I think adequate nutrition is very important during pregnancy. But like I said before, there is some degree of, a protection of the baby, even if the mother doesn't get enough food. But still, yes, my answer would be yes, it affects the baby. It affects.
Okay, thank you, ma'am. One more good question. Ma'am, in summer season, sorry, do we need to give water along with breast milk in first 6 months?
No, you
Will
give,
take
you
care
give,
of baby or may not have
no,
dehydration? Should we give or not?
not give, give it to the mother. That is
Okay.
what we normally tell. So, the thing is, it sort of filters down to the baby. It will
Okay.
go to the baby. So, and in fact, I mean, mothers feel extremely thirsty during summer season, So that's because the little one is taking all the water he or she needs. So no, please don't give water. Always there is, this thing of introducing infection. Another thing, if you have somebody older person in the house, though well meant, many times they may just add sugar or something to that, and it just causes chaos with the breastfeeding. So if the breastfeeding is well set, you give the water to the mother. Don't worry about the baby. The baby will get it himself or herself.
Okay. Thank you, ma'am. Breastfeeding is more psychological thing. Is it true? Like the production of milk is based on their psychological state. Is it?
It's not only on the psychological state. The other very strong stimulant is the sucking of the baby. So when the baby sucks, it actually helps to release some hormone called oxytocin from the brain of the mom, from the pituitary, and that actually causes a secretion of the milk. So yes, psychology plays a part, but it is also the baby sucking. So the more number of child times that the baby feeds, the mother will secrete more and more milk. That is there. So though there is a part of psychology, there is also a very much physical part to it.
Okay, thank you, ma'am. And one more question. Even many of us have this in our mind. There is a lot of confusion regarding the right age to start the complementary feeding. Is it 6 months or can it be started at 4 or 5 months also too?
So once again, I would just quote the WHO. So initially, in fact, when we did our training some 25, 30 years ago, at that time it was 3 months. But now they have made it 6 months. So we stick with 6 months. Just stick with 6 months. But there is always a caveat. If the baby is not growing, if the baby is falling off the chart, then of course you may have to feed, you may have to give complementary feed. But normally we would say 6 months.
Ma'am, they say that exclusively breastfeeding for 6 months.
Yes.
But is it possible that it is exclusive without giving anything? I mean, even water
Yes,
or
very much possible. It's very much.
possible?
Yeah,
Oh,
very much.
oh, okay. When can we do bone scan to see fusing of bones and hence assess height? Is it necessary?
So, so you need to do a bone age. It's not necessary.
Uh,
So, like I said, when a girl starts her period, roughly 1 year after that, 1 to 1.5 year after that. So, when a girl has her periods, the growth rate slows down after that. So, the long bones, the hands and legs, the arms and legs, their growth stops after that, and it's mainly the spine. So, generally, girl, unless it's a very thin girl, otherwise, roughly 1.5 year, 1 to 1.5 year after the period has started, the girl stops growing. And for a boy, um, once he starts shaving, the growth has stopped. So you don't need a bone scan. It's not required. So these are two very, very, obvious parameters that can be known. Now if you want to know how much growth is left, then you need a bone age, which is a left hand x-ray, and that needs to be assessed by an endocrinologist to tell you what is the bone age and how much growth is actually left.
Okay, thank you, ma'am. What could be the reason for fetus not gaining weight despite mother receiving adequate nutrition?
Oh, there are umpteen reasons. So
Yes, ma'am.
there are maternal reasons, there are reasons of the placenta, and there are reasons of the fetus. So if there is any degree of sickness in any of these, the mother has some issue, either she's a diabetic or she has some infection like tuberculosis, or the baby has a renal issue, or any other problem is there in the baby, which could be umpteen, or there are placental problems. So nutrition is just one part of the story. The rest is really in God's hands. There are too many things which are there. There are maternal, fetal, and placental problems which can actually result in low weight.
Okay, ma'am. Thank you. Source a newborn baby. Can it be cured with the diet given to mother? Source.
What in the newborn baby?
Source. SORES. Source.
No, 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 no. The for a sore, the baby has to have treatment.
Ah, oh,
Maternal diet will not heal it because it is something local, right? So it has to be. So mother actually gives the baby a lot of immunity. So she gives the baby enough, immunity to fight against infections. Protein, especially the first, as you know, the colostrum is very important. The protein in the mom's milk is very important. She actually helps the baby to fight against infections, which she has experienced herself. But something like a sore, it is best to treat locally. Best to treat locally.
okay. Thank you, ma'am. What if the height curve flattens for 2 to 3 months?
Depending upon the age. If the child is under 1,000 days, I
Yes.
would look at if something is wrong. If it is older child, especially now, see, we were talking about first 1,000 days, but if you look at roughly 4 to 8, 9 year old children, so they grow only 5 centimeters a year. So maybe 2 to 3 centimeters the child will not grow. Another thing, children, especially in the older years. Now this does not the first 3 years. In the older years, children have phases of growth and phases of not growing well. For instance, summer holidays, children are at home, unless they're in a lockdown. When they're at home for 4 5 months, they eat well, they are jumping around, they're playing, they're happy, they tend to grow more. School days, sometimes they grow less. So children have phases of growing and not growing. So I would say in a younger child, yes, 2 3 months I would worry. In a 10-year-old, I wouldn't bother. I would just keep an eye on what is going on.
Okay, ma'am. I think two more questions we will wind up.
No problem.
Uh, when the baby is commonly very active but does not gain weight adequately according to the growth chart, but is a linear growth, does one still consider to be a slow growth?
So generally, if the length is okay,
Uh,
the weight is roughly okay, I would be all right. But at least the child should stick to her or his own centile. If the child is dropping, then I would worry.
okay, okay. Fine, ma'am. The last question we take.
Sure.
Pressing placenta slowly and pushing blood in baby's body before cutting the umbilical cord may prevent juvenile anemia and may give more immunity to baby. Can it be practiced?
So it is, yes, it is advice, especially in in areas of the world where you don't have too much health care afterwards. Yes. So immediately in the postnatal period, it is definitely helpful. But the iron deficiency anemia generally starts at around 6 months of age. It doesn't start before that. So once you start complementary feeds is when the anemia starts. Or if a child is on cow's milk, when you have all this solute load, which actually causes anemia in a little one. So we call it cow's milk anemia also. So for them, yes, but so the protection that the baby has is short lived. It is not, it will not prevent anemia when the baby is 9 month old. No. And the anemia happens a bit later because the iron in the mom's milk is very easily absorbed actually by the baby. So in the immediate postnatal period, yes. Afterwards, no. Afterwards.
Okay, ma'am. thank you very much for patiently answering most of the questions posted by our participants. And really, once more, thank you for accepting our invitation and giving a wonderful presentation to our participation. So, thanks from NSI Bangalore chapter. Thank
Thank
you, ma'am.
thank you, everybody. Thank you.
I thank all the
Um,
participants for patiently being with us and listening to the session. And tomorrow we have on the breastfeeding week theme itself our presentation. So it starts at 3:30. Now the feedback form is posted. Kindly fill in the feedback form. Thank you so much. All.
Thank, thank you.
Thank you, ma'am.
Thank you.